Greetings, everyone. I think we're ready to start. Firstly, can we get an indication if the sound is coming through clearly on your end? Okay, great stuff. Thank you for that. Welcome to the NIOH, the National Health and the National Health Laboratory Services. I am Tanisha Singh, leading the NIOH outbreak response team in terms of our COVID response. And we are very pleased to have the environmental health practitioners joining us today. It has taken some time to organize this session, but we are very glad that it is happening. We have a very special guest from the National Department of Health, the Environmental Health Directorate, that is co-hosting with us today. And just in terms of the NHLS, for those of you that are new to these sessions, the NHLS provides a diagnostic service to 80% of the South African population, and the NIOH is a complementary division to very similar to the National Institute for Communicable Diseases that many of you may be familiar with. Our main goal is ensuring healthy, sustainable, and safe workplaces. In terms of these sessions, we've been running a series of sessions on COVID awareness and preparedness in the workplace, and today we're reaching out to the environmental health practitioners. We do have a series of sessions that will be taking place in the coming weeks, and we will be sharing invites with you. So if you wish to join, we welcome that. In terms of the session, you will be muted throughout the session. But if you have any questions, please indicate your questions on the chat bubble, or you can put your questions in the Q&A bubble. And then we will have a session at the end to address some of the questions that we can't address. We will address it through email or on our website. So with that, I'd like to thank you for your time and for joining the session today, and hand you over to our program director, Mr. Ashraf Raycliffe, that will take you through the proceedings for the session. Thank you. Over to you, Ashraf.
Thank you very much. That was Dr. Tanisha Singh, the head of our immunology and microbiology, immunology and microbiology section, and as she mentioned, heads the NIOH's COVID-19 outbreak response team. So our program for today, for you as environmental health practitioners, we've had over 1,000 people registering, and the tally of people who are currently logged on is edging towards 650 people logging on. And we hope that your sound and all of your video and sound is good. So the program for today involves the update on the COVID-19 by Dr. Odile Valmink of the Occupational Medicine section. That will be followed by a recording of Ms. Panika Matuka, Ms. Tikeledi Matuka, dealing with risk assessment, which you would be very familiar with. In this case, it's risk assessment in a specific new context of COVID-19. And then that's followed by the demonstration of donning and doffing of gloves and respirator. We have then our guest from the National Department of Health who will deal with COVID-19 environmental health guidelines. And thereafter we'll have a panel session on question answers. I hand over to my colleague, Dr. Odile Valmink. Thank you.
Hello everybody, and thank you for joining us today in our session, all the environmental health practitioners. So what I'm going to be doing is I'm going to be giving a little bit of an update on COVID, and I know this is something that we all know about already because we've been inundated with information on this topic, but it's just a continuously evolving topic. So here are some websites to keep you updated. There's the NHLS website, NIOH, NICD website, the National Department of Health website, the WHO, even the CDC website. So this slide just helps for you to continuously go for updates information. So currently where we stand, there's more than 2.5 million people who have been infected with the coronavirus. And it's resulting in more than 180,000 deaths globally. And these were stats from the 23rd of April. In South Africa, we have 3,953 confirmed cases and 75 deaths so far. So in terms of transmission of COVID-19, we know that initially there was transmission from countries, and it was acquired from countries where there was a high-risk countries, and then kind of sort of, once it was in South Africa, we know now there's also community spread, but there's also been reports of occupationally acquired COVID-19 in South Africa. So we know with regards to transmission of the virus, it is transmitted by droplet spread. And so when somebody is coughing and sneezing, they generate droplets which are initially in the air and then settle to surfaces. And that is why we have social distancing, so that we are not in contact with anyone else's droplets, just to decrease the risk of transmission. Now, with regards to the persistence of COVID-19, it's thought that the virus has a fragile outer membrane that is sort of less stable in the environment and can be killed by simple disinfectants, which we'll hear a little bit more about that later. The survival time of the virus in the environment depends on many factors, such as the pH of the environment, the inoculum size, how much concentration there is of the virus, the dryness of the environment, the temperature, the exposure of the environment to disinfectants, and the type of surface that it rests on. Common disinfectants such as 70% ethanol and bleach can kill the virus. And at the bottom, you may be able to see a little diagram about, there have been studies on how long the virus survives on different types of surfaces, and wood, it says 4 days, steel 48 hours. So depending on the type of surface, it can be stable for different lengths of time. So COVID-19, the common symptoms include a fever, cough, shortness of breath. Can also be sore throats, as well as difficulties tasting, difficulties smelling, pain of your body pains, as well as tiredness. But these are the common symptoms. And so according to the NICD, the National Institute for Communicable Diseases, a person who needs to be investigated is a person with acute respiratory illness with sudden onset of at least one of the following: cough, sore throat, shortness of breath, and fever. And these would be people who would then go on to have a diagnostic test done, where oftentimes you do an oropharyngeal sampling or a swab, and this is then tested by PCR for the virus. Okay. Now, with regards to exposure of COVID-19 in the workplace, there are many ways in which it can get into our workplaces. It can be from workers who acquire this in the community and then come into the workplaces, or within the workplaces be exposed to either colleagues or as part of the job that they do, come into contact with SARS coronavirus 2 and acquire the COVID-19 disease in the workplace. So there are different workers that are at increased risk of getting occupationally or workplace acquired COVID-19. And these include healthcare workers, emergency response and public safety workers, people who deal with post-mortems, laboratory workers, environmental health workers, as well as other workers like airline operators, retail workers, correctional facility workers, solid waste and water management workers, and people who part of their job requires for them to travel to high-risk places, which at least now with the ban on travel is not such a risk, but as bans are lifted and levels are changed, this would also be a risk factor. So how do we try to control the risk in the workplace? We sort of go back to basic principles and we look at primary prevention strategies. And the primary prevention strategies talks to how do we prevent workers from getting the disease in the workplace. And here we need to minimize the risk of transmission by our usual things where we do the health risk assessment, which Annika will be talking to in detail a little bit later. And these, after the health risk assessment, we look at controls in the workplace with regards to engineering controls, administrative controls, PPE. We also look at preparedness of the workplace to try to continue with business and looking at policies that can be put in place in terms of mitigation of the risk in the workplace. We also need to do education and training and communicate this risk to our workers as a way of decreasing the transmission. Then we look at secondary prevention strategies. And this is where a disease occurs in the workplace, we need to pick this up early so that we can isolate people to ensure that spread doesn't occur, and also that these people are treated quickly. Then we look at tertiary prevention strategies, and this looks at complications or preventing complications from the disease with regards to rehabilitation, incident investigation and contact tracing, compensation where it's appropriate, and looking at leave for the employee. So with regards to risk assessment, which I know you guys are very well aware of, the purpose of this risk assessment would be now to look at determining the risk of exposure to COVID-19 within the workplaces with regards to the different operations that are in place, the different activities or tasks, looking at shared spaces for employees as well as engagement with employees and the public. And this risk assessment needs to be communicated to all people within the workplace, not only the workers, but as well as visitors as well. And once we are able to identify the risk and categorize the risk, we need to look at the controls. We need to look at elimination of the controls, which I wish we could do in this case, or substitution, which is not quite a possibility, but is there a place for separation or isolation or engineering controls within our workplace? Is there a place for looking at organizational, procedural, administrative controls within our workplace? And what are the PPE requirements? And all this is based upon the risk assessment that we do. Types of administrative controls that can be put in the workplace that need to be revisited and looked at in light of the COVID-19 epidemic and the risk it poses to our workplaces. We need to think about infection prevention and control and standard precautions, and we need to review those policies and be trained on those policies maybe again. We need to look at maybe controlled access and practices around access control to avoid overcrowding of high-risk areas. We need to look at workplace facilities. We need to look at adequate staff and office space. Sometimes we need to think about, just like our president said, where it is appropriate to work off-site to avoid overcrowding. We need to limit the number of meetings, maybe using teleconferencing, video conferencing. We need to minimize travel where appropriate to work from home. We need to avoid mass gatherings and events. We need to ensure there's proper signage, proper risk communication to our staff, as well as visitors who enter our facilities. We need to review our cleaning and our disinfection material and supply procedures. And we need to look at established public health reporting procedures and to see where if there's a case, how these can fit into our work. We also need to have guidelines, action plans, and protocols where somebody comes into contact with a confirmed case. So these are some examples of the administrative controls, the policies, the SOPs that need to be revisited in the workplace to be made appropriate in your setting to control and mitigate the risk caused by COVID-19. Another important strategy is education and information of employees. So communicating risk by doing education and training. We need to give our employees facts about how the disease is transmitted. We need to speak to them about infection prevention and control with regards to hand hygiene as well as respiratory hygiene practices. Where PPE is indicated, our employees need to know the correct donning and doffing as well as the disposal of this PPE. We also need to advise people who have been exposed or people at high risk of self-assessment, looking for symptoms and where to report these symptoms and what sick leave policies are in place if people are exposed. Influenza vaccine has been documented to prevent possible co-infection with influenza as we go into the flu season in our country, and that could be made available or encouraged to have this outside of the workplace to ensure that co-infection doesn't occur. People also need to understand travel risk and make informed decisions when the bans are lifted. And just for people's information, this is the public hotline number for NICD. So people need to be made aware of all these things within the workplace. And it's important not only to sensitize the skeleton staff that is on site, but also to communicate this to staff that is home, and also key operational people with regards to HR people, our security staff who access control personnel. People need to be aware of what are the procedures to be followed, and all these reviewed procedures need to be communicated to staff. With regards to personal protective equipment, it's important to remember that this is only an effective measure within a complete package of mitigation and control strategies. So if we look at the bottom, that little hierarchy of controls, PPE is always at the bottom because it's the least effective means of controlling the risk. We need to, where it's indicated, we need to ensure that it's adequate and appropriate PPE is used, and this is determined by the risk assessment. PPE that is used should be discarded in accordance with safe practices. And surgical masks also need to be available for people with respiratory symptoms that either come into the workplace or if we're going out to scene in the community. So we spoke of primary prevention strategies that are decreasing the risk of COVID-19 coming into our workplaces, which would be the health risk assessment primarily, and then followed by engineering controls, administrative controls, and lastly PPE. But in terms of secondary prevention, medical surveillance forms part of secondary prevention strategy. And in terms of COVID-19 risk, this should also be done and determined according to the health risk assessment. So medical surveillance is always risk-based. There's never a blanket protocol for everybody. It ideally should be done according to the legislation and the guidance of the occupational medicine practitioner. And the purpose of medical surveillance in terms of the COVID-19 epidemic for employees who are at high risk of getting occupationally acquired COVID-19. The purpose is for early detection of infected employees so that these employees are removed from the workplace and isolated, and also referred for appropriate treatment and care so that they can get better and come back to work in a timeliest fashion. It's also important to prevent spread to other unaffected staff, to unaffected consumers, visitors, and clients of the business. And this is allowed by prompt identification, allows for this in isolation, quarantining, contact tracing, where someone has been in contact with someone who is infected in the workplace. There needs to be effective return to work practices, and where it is necessary, workplace restrictions once an infected employee now needs to come back into the workplace. So the types of medical surveillance or screening that can be done include symptoms questionnaire, looking at does somebody have a fever, does somebody have a dry cough, does somebody have shortness of breath, all the symptoms. And also temperature screening can be used, but it's important to remember that temperature screening shouldn't be used in isolation, just because there may be issues with temperature screening where we may miss certain people. With regards to people who are immunosuppressed, sometimes even the elderly or people who are taking certain non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, these people may not have a fever at the time of testing, but could be a positive patient or a positive person that we're missing in the workplace. So clinical judgment needs to be used when testing employees. And sometimes people with symptoms that are not typical, like body aches, nausea, vomiting, diarrhea, abdominal pain, headaches, runny nose, loss of taste and smell, need to be assessed by the occupational health staff. Or even people who have a temperature that may be slightly high but not to a point of 38 degrees Celsius. These people may need to be tested by the occupational health staff to see whether or not testing is warranted. Okay, so policies and protocols need to be in place that look at medical surveillance for employees who are at risk. Now, if there's a case where an employee is infected or exposed in the workplace, on returning to work, particularly with employees who have been who have been infected, then now coming back into the workplace, these infected or post-infection, these employees should ideally undergo a medical evaluation to see if they are fit to work. Ideally, the guidance is that they should wear surgical masks at all times while at work for a period of 21 days from the initial positive test. For everybody, but particularly these people who are post-infection, we need to implement social distancing measures, and we need to ensure adherence to hand hygiene and respiratory and hygiene as well as cough etiquette within the workplace. And they should continue to self-monitor for symptoms, respiratory symptoms. And should symptoms reoccur or get worse, they need to seek medical attention. This is just particularly for the case of healthcare workers. These people shouldn't actually be working with immunocompromised patients. And where it is appropriate, if the medical practitioner feels that the infection with COVID-19 in an employee is occupationally related, they need to report it as appropriate to the Compensation Commissioner in line with the COIDA Act. So our medical management of these people we need to ensure fitness for work and return to work, and we need to have a protocol for that. We also need to think about the mental health issues that come along, the increased anxiety and stress and burnout that comes along in dealing with the COVID epidemic in our situations and our workplaces. After infection, if should somebody be infected, we need to look at impairment assessments and compensation as appropriate and look at workplace restrictions that may be necessary. So just in terms of, I know this is repetition, but just to say it again, we need to, within our workplaces, think about minimizing the risks of transmission of COVID-19 within our workplaces. And in order to do this, certain policies, certain protocols, certain SOPs need to be in place. And the procedure should involve screening and identification of potentially affected employees. And our employees, we need to limit contact and movement. We need to look at reviewing our health risk assessment in line with a new hazard that is coming to our workplace, and reviewing the hierarchy of controls and putting in controls where we feel they are deficient. We need to look at and reinforce social distancing even as we come back to our workplaces. We need to promote regular thorough hand washing by our employees, by our contractors, by our visitors, by our customers within the workplace. We need to ensure that people are practicing good respiratory hygiene, avoiding touching their face, especially while they're working. And anyone who is symptomatic should be encouraged to stay at home and isolate. Okay. This slide just is for your information that should you have any queries, particularly with regards to workplace issues around COVID-19, there's an email address. It's info@nrh.ac.za, and this is to send emails where you have your query, and we will try to promptly address your queries. We also have a helpline for workplace advice that is run by the occupational medicine section. And the phone number, it's a toll-free number, it's 0800 212 175, that you can get telephonic advice. Should we not have the answers, we will try to research your questions and get back to you with an answer. There's also the NICD hotline for clinical management of cases. There's 0800 29999. Thank you so much for your attention.
Well, thank you very much, Odette. So that covers the question of the update on COVID-19. The National Institute for Occupational Health, as Odette has brought to our attention, has got quite a lot of resources, and I'm going to encourage you through the chat box to visit our website and to indicate to you where some of the resources are. For example, we've done a BioRisk assessment session early in April that deals with frontline workers, and I think you will be dealing with various types of frontline workers. Our next topic for this program is, in fact, then a risk assessment by Ms. Annika Matuka, and I'm going to ask Jane just to get that on for us. In the meantime, a reminder, please, at the bottom of the screen, you have the chat with bubble, and you also have the Q&A bubble. Please type your questions you have there for our question and answer session later on. Thank you very much.
Thank you, Asha. Good morning, everyone. Today I'm going to present to you BioRisk assessment for COVID-19 for frontline workers. So this will be the first session, and after a few speakers, I will follow through with the BioRisk assessment tool. So, workplace BioRisk assessment is defined as the process of determining the risk associated with exposure to a particular biological hazard and evaluating the existing controls and deciding if the risk is acceptable or not, with the aim of protecting the health of the worker as well as that of the public, and to prevent or reduce exposure in any workplace. This will also inform what mitigation strategies to be put in place in different workplaces. Biological risk is the chance that the biological material can cause harm to the health and safety of a person. And there are different types of hazardous biological agents. Those include bacteria and the viruses, which is our focus today, fungi, parasites, allergens, as well as the microbial bioproducts that are produced by different microorganisms. And the proximate sources can either be people or human, or it can be the environment that we work in, as well as plants and animals. For today, when focusing on workplaces, the main sources will be your people and the environment you work in when it's contaminated. So hazardous biological agents are classified into 4 groups. So the main group that is our focus today for coronavirus, because we know that it can cause severe human disease and it can be a serious hazard to the exposed worker, and it can spread to community. And we all know there is no treatment available at the moment. So we will classify it as a group 4 until there has been a treatment found. Then it will probably downgrade to a group 3, which also can cause severe human disease. It's a serious hazard to exposed worker, can spread to community. But for group 3, there is effective treatment available. So in order to conduct BioRisk assessment, one needs to know the difference between the 2 terms. You need to know what is the hazard. It is defined as anything that can cause harm to the health and safety of a person, whereas the risk is the chance that a person will be harmed by this particular hazard. It can either be high risk, medium risk, or low risk. So it's important to differentiate between these 2 terms for the effectiveness of BioRisk management. So why is BioRisk assessment necessary or important? Firstly, it is a legal requirement under the Occupational Health and Safety Act. We get the hazardous biological agent, which requires the employer to protect their employees and make sure that they have a safe working environment. So the other reason is that it's the key for prevention strategy. So while you're doing your policies on infection prevention and control strategies, this is an important thing to do and to include in that policy. And then it's mainly to determine the risks associated with the biological agent, coronavirus in this instance. And the risk assessment must be done at the beginning as well as continuously. So the regulation recommended it be done every 2 years. However, it should also be done when there is any change in the environment, when there is any change of equipment or building. Like now, because of the emerging pathogen, which is the coronavirus, risk assessment needs to be relooked at. And it must be done in consultation with Health and Safety Committee, and the records must be kept for 40 years as recommended by the hazardous biological agent regulation. So there are 4 main pillars of risk assessment. The first step is to identify the hazards. So there you look at the different occupations, and within occupations also you can find out that people does different activities. So it must be done by activity or a process that's taking place in the workplace. And then the second step, then you decide who will be affected. So you look at your workers, you look at different positions or tasks, then you identify those people and you record who can be harmed and how they can be harmed based on the processes that they do or the work that they do. And the third step, you evaluate the risk. That's checking the likelihood that harm may occur and the consequence from being exposed to that, whether there is severe or there will be any loss of human life, and the number of workers exposed at the time of work or at the time of risk assessment. And then we determine what existing controls are in place and if they are adequate or if you need to add on extra measures in controlling the risks. And lastly, BioRisk assessment must be recorded, because if it is not recorded, it's not done, and then an action plan needs to be taken into consideration of when will this mitigation strategies be put in place and who should be doing this and when is the deadline. That should also be recorded. And the risk assessment must also be reviewed periodically, as I've mentioned, when there is any change of some activity or equipment or anything in the workplace. So basically, the BioRisk assessment approaches depend on the nature of the workplace. What are your sources where you're working, or indirect or direct sources? And then the type of processes that you work. So for various workplaces, you know your workplace better, you know the activities. So while listening to this or while doing a risk assessment, determine what activities are there and associate them or link them to the risk assessment tool and see how you can best fit it. The task performed at the time of conducting assessment is also critical. Risk assessment is not done when a person is sitting in the office and just thinking, okay, this person do this person do this, so I can do this. Yes, it may be costing in your mind, but actually the best way to do it is to go physically and observe the worker doing the tasks and record what you see. And also ask the questions, because it's important. The employee might provide you with all the necessary information that you will need. You might not know everything that they do. And also, on that particular day when you're doing risk assessment, they might be skipping a certain step which they usually do in their normal processes. So they will be able to tell you if they are not doing it at that time. And then lastly, the technical complexity of workplaces. As we all know, all workplaces differ and they have different processes within their environment. So there are common mistakes that are made when doing BioRisk assessment. It is usually seen as a once-off process, but actually risk assessment is an ongoing process. Sometimes it's not even documented, or people take it as a tick box exercise. Like I said, a person will just sit in the office and just tick because they know that there will be an audit or an inspection, so they want to have documents ready in place, and that shouldn't be the case. It must be done properly, because the important aim or goal is to make sure we protect our workers. Sometimes workers are also not involved, so it's recommended that when you do risk assessment, you involve the worker and encourage them to also report if they see there are any additional risks that have been probably been missed, so they can share the information, and that can be included in the BioRisk assessment report. And hazardous biological agent risk sometimes is not assessed fully because people have little knowledge on when it comes to biological agents. But then they can ask assistance from those with expertise or those who have the background on what to do for. And the preventive hierarchy, as mentioned by the previous speaker, is critical because that is going to help you when you need to mitigate, because that will guide you on what control measures to put in place. And long-term risks are sometimes underestimated or denied. So the challenges with doing the risk assessment, in particular for the coronavirus. Currently, there's uncertainties about the virus. As you know, it's all evolving now. There is no like certainty of actually what this virus do. But we have some information. We can work on the current information that we have on exposure as well as on how the virus behave. And there's also currently lack of treatment as a control measure. So other alternative measures like supportive care for those who are affected can be put into place, your self-isolation and so on. And then I've spoken about the classification of the virus, which is not for sure for now, but based on the regulation and the definition of the different classes of HBAs, then for now we classify it as class 4 because there is no treatment available. The other challenge is shortage of resources for mitigation as well, because there's lack of respirators, lack of masks, but people are trying, or workplaces are trying as much as they can to acquire those resources and make sure they are used appropriately. And then the field testing, which my colleague after is going to talk about, it's also a challenge because at the moment, because of the rush, because of the fear, people are just buying masks or respirators, and they're just wearing the respirators without fitting. How do we know for sure that it's protecting the worker? How do we know for sure that it's fitting when field testing is not done? Individual susceptibility also. People define, they respond differently from exposure to hazardous biological agents. And yet those that are immunocompromised as well with underlying conditions, those that are more vulnerable than the normal healthy workers. So emerging pathogens are a challenge, and this coronavirus is one of the emerging pathogens which was similar to the SARS and the MERS that happened previously. So people need to always be alert and be informed as it's evolving. The more information we get, the more update we get, and we know what to do on mitigating the risk or preventing exposure of the worker. And then also to emphasize that risk assessment should be updated when required. So things to consider when conducting biorisk assessment. We must remember that microorganisms are everywhere and they are invisible. So there is no way you can avoid them. And then hazardous biological agents cannot be eliminated as they are there. So the best thing to do is to minimize the risk at each point of chain of infection, which is from your source. You can break the chain there, or break the chain at your host, or even at your environment. But the best way is to start at your source first, because you don't want it to go any further. Checklist for assessing the risk of biological hazard is not standard, so it will differ by sector. Whatever tool you have now, you can still apply. Just make sure that it covers basically all the necessary information that is needed about the hazard, about the risk, who in your workplace will be affected, and what health effects. We already know now the health effects for the coronavirus, what they are. And then also look at your high-risk groups in your workplace. that information will be found with the occupational health practitioners or professionals. So when you do risk assessment, because it's not always the case that the person who does the assessment will have access to information, because it's confidential information that remains with the medical practitioner. But it's important that the person that does the risk assessment must share the report with the org health professional or practitioner, so that they are able to see which group to focus on, or which workers to focus on that can be more at risk. And after doing risk assessment, it's important that you communicate the risk so that everybody knows what's happening in their workplace, what hazards they are exposed to, what risks and health effects they can be prone to. So include your workers in this communication, include management as well, as they are the ones who put together policies in place for different workplaces. And they will also be able to allocate resources where there's a need to probably, for example, install any device or to buy your respirators and whatever mitigation strategies you need that requires a budget. So involve management as well. Engage all committees in your workplaces that has to do with health and safety. If you have the BioRisk Management Committee or the Outbreak Response Task Team at the moment, they should be actively involved. Your occupational health practitioners or professionals, your health and safety people has to be involved, as well as the infection and prevention control committees must be involved in this process, or the discussions for that matter. And then where there is gaps or lack of expertise or uncertainties, you can still contact your external advisors who will be able to help you or advise you on closing those gaps or on filling up that information that's lacking. So there are certain limitations when doing BioRisk assessment. The assessment is not quantitative, simply because there are no occupational exposure limits for biological agents, as compared to chemicals where you get a certain figure to say this is the limit, you shouldn't reach this limit. With biological agents, it's different. And you get a whole lot of diversity of microorganisms. So it won't only be the coronavirus in your environment, there'll be other biological agents. So while doing this assessment, focusing on coronaviruses, think of other biological agents as well. And importantly, microorganisms can replicate at any time. So whatever you find at that moment, when the environmental conditions are conducive, high temperatures, high humidity, microorganisms can replicate and reproduce. Some can mutate, like the coronavirus at the moment, which makes it more difficult because it will keep changing. And then lastly, the susceptibility, variability between different individuals. People respond differently to exposure or to microorganisms. Therefore, that makes it very complex. So it doesn't guarantee non-exposure or absence of all risks, because you're doing it looking at observing the task at the moment and on a particular day, which may differ with other days. And unknown and uncharacterized biological agents are also a limitation or a challenge, because like now, coronavirus currently, like I mentioned, it's not classified whether it's a group 3 or 4, but we base it on the current knowledge that we have about the virus. People can make errors as well while working, or they can ignore, although they have information in place or procedures in place, they may ignore what is in place, and that can lead to incidents. So we must try hard to avoid such. And it also depends on availability of resources. As mentioned, involve management so that you are better off prepared in order to put control measures in place. And there's lack of competent staff or expertise to conduct biorisk assessment. So this is another limitation, but as I've said, you can involve other people as well, or your external advisors. So just to mention a few like mitigation strategies that's usually now like practice. I just want to highlight that for contact, gloves must be used properly, so the donning and doffing of gloves must be done properly by the workers. But my colleague Taban is going to do the demonstration on how to don and doff gloves, and as well as when we look at this picture, it's a police officer wearing gloves. Based on the current activity that they are doing, the question is it necessary for them to put on gloves? So the other concern is, as mentioned by the previous speaker, Tanusha, the gloves can harbor microorganisms for almost like 8 hours. So the question is, when they are having gloves and they are touching different cars, how many cars are passing on that route? You're touching one car and they probably don't have extra pair of gloves, because we also need to consider using resource wisely. So she will be touching the one car and moving to another car and to another car. That may pose a risk to the public as well as to other people like the co-workers as well. So we must be cautious on which PPE we use for which activity. Same as respirators. It must be provided to the right people, but Jeanette is going to talk in detail about this. But the important thing here to highlight is that it must be worn properly, and then a seal check must be done so that to ensure that the worker is protected. If you look at the picture at the bottom, it's one of the pictures I took from TV last night. It's someone wearing a respirator. Is this respirator worn properly? And is this respirator fitting? Judging from how it's sitting, I'm not sure, but those are the points to consider when you do respirators. So in conclusion, risk assessment is part of everyday life. So where you work, as you're doing your work, as you're moving around, you're doing risk assessment. So just keep it simple so that every worker must understand what they need to do, what their hazard is. Don't complicate it with complex tools, because then people will be lazy to look at it and they won't comply. And ensure that all employees understand it and what is required of them, as all employees also have an obligation, the same way as the employer has an obligation to provide a safe working environment. Employees must also play their part, and then you just say what you do in your action plan, and you do what you say you're going to do within a specific deadline. Thank you.
Well, that was the presentation on a risk assessment, and that was specifically focusing on risk assessment, the new risk assessments given the coronavirus as the hazard, the biological hazard, and COVID-19 as the disease that results, the occupational disease potentially as well, in the case of some of our workplaces like the frontline workers. That was Ms. Monica Matuka from the NIH's Immunology and Microbiology section. The next video, and this was recorded in a different venue, so the sound is not the best, but we are learning as we are doing in our Zoom sessions, and we will improve that for you as soon as we can re-record that particular session. The next one is on the demonstration of donning and doffing of gloves and respirators. A reminder, please, the chat button at the bottom. Type your questions there for the question and answer session. Thank you.
And I'll be taking you on the doping and the drawing of gloves and respirators. So firstly, I'll start with the gloves. So in this case, I'll be using the nighttime disposable gloves. So before you wear your gloves, remember it is important to make sure that your hands are clean. So in this case, I will use the hand sanitizer to disinfect to clean my hands, and then after that, before I even touch any of my PPE. So the other important things before you wear your gloves is to make sure that your hands, you don't have any germs, because those ones, they can interfere and they can also cause some tears on the gloves. So since my hands are clean now, I will start by donning the gloves. So also on the gloves, also there's different sizes, and it will also depend on the size of your hand. So in this case, you select the correct size based on the size of your hand. So I will start by donning. So when wearing the gloves, you make sure that you insert the first glove, and then you pull the tip of the glove to cover the wrist area. It's covered. And then you take the second glove. It's the same sequence, and then you wear it, and make sure you pull the tip to cover the wrist area. In this way, my gloves are well. And then also you have to check any visible tears so that you don't become infected with anything, whatever you are working with. So in this case, my gloves are worn correctly. So now I'll come to the doping of the gloves. So for the doping of the gloves are now contaminated. So the aim here is to make sure that you do not touch the contaminated areas of the gloves with bare hands, because in that way you'll be defeating the aim of wearing the glove in terms of protecting your hands. So in this case, I have two methods that I'm going to demonstrate for doping. So this one is the one that is recommended by the World Health Organization. So when doping, you make sure what you do, you pinch the gloves at the wrist level, and making sure that you're not touching your hand. And then what you do, you peel it away, not touching, and to turn it inside out. And then after that, you use the gloved hands to contain the other gloves. And then after that, what you do, you slide your finger between the wrist and the gloves, not touching the surface which is contaminated. And what you do, you peel it away to cover the gloves inside and out, and to engulf the first glove. And then from there, you throw them into the bin. So that was the first method. So now I'm going to demonstrate the second method. In terms of donning, is the same procedure that I used. So this method for donning, we call it the picking method. So I'm still going to wear the glove the same way. Nothing has changed. Same sequence. Adjust, and then check any visible tears, and then now come to the doping for the picking method. So with the picking method, what you do also, you pinch the glove right near the wrist area, and then you peel it, and then you form what we call a B. So if you can check now, the contaminated area is now covered. So now you have your clean area. So what you do, you use this area, which is the B, and then you pinch it, and then to avoid touching your skin, and then you peel it away, and then throw it into the biohazard box, and then from there you use your hand to just remove it, and then you use your finger, and then that's it. We are done. And then now I'm going for the respirators. So with the respirator also, you make sure that you disinfect your hands before you touch the box, because you do not want to contaminate the PPE. So we have two different types of respirators here. So I'm going to start with the V-Flex one. So you simply remove the respirator from the box. And then for this one, what you do, you put all the fingers of both hands onto the nose piece, and then you make sure that the thumbs are underneath. So gently you bend in the middle of the nose piece, and then after bending, what you do, you unfold the respirator by pulling the bottom part downwards and pulling the top part, which has the nose piece, upwards. And then you make sure the straps are on the top level. And then what you do now, you use one hand, you place the respirator on your face, and then the top part must be, the nose piece must be on the bridge of your nose, and then the bottom part to cover your chin. So with one hand, you pull the first strap below your ears, and then you pull the second one on top of your head just above the ears, and then you check if the straps are aligned well. And then what's next? You can use these tabs to adjust for proper fit. And then after that, you use the fingers for both hands to adjust the nose piece. You start from the bottom, going downwards, and then when it's adjusted, the next step, you perform what we call a seal check. So with the seal check, you put both hands onto the respirator, and then you exhale out sharply. In that way, if you feel any air coming out, if it's on the top of the nose piece, what you do, you adjust the nose piece, and if it's anywhere on the respirator except on the nose piece, you can use the tabs or you can adjust the straps. And then after that, you do the seal check again to verify. So if everything is okay, you are good to go now. So now coming to the doffing. For doffing of the V-Flex respirator, so now the respirator area, the front area, is now contaminated. So your aim is not to touch the contaminated area. So what you do, you slide your finger, and then remove the first strap, and hold it, and use another finger to pull the second strap. Avoid touching the respirator which is contaminated, and throw it into the biohazard. And that's it for the V-Flex. So now coming to the N95 respirator, which is the easiest one to do. So with the N95 respirator, you have, assuming you have disinfected your hands. So what you do with this one, you place it onto the palm of your hands, and then you allow the straps to hang, and then you place it on your face with the top part which has the nosepiece on the bridge of your nose, and then the bottom part to cover your chin. So from there, you pull the top strap and place it above the ears, and then you pull the second strap and place it below your ears, and then you come and then adjust from the nosepiece, starting from the bottom using both fingers, going down, and then after that you perform a seal check by examining sharply. In this case also, if you feel the air coming out on the top, you readjust the nosepiece. And then if there's any other area also, you can readjust using your straps. And then you perform the seal check again to verify. So in this case, you are good to go to perform your duties. So after that, now we come to the doffing. The doffing, you also avoid touching the contaminated areas, which is the surface, the front surface of the mask. So what you do, you slide the fingers, pull the first strap, hold it, and then you pull the second strap to avoid touching the surface of the mask, and then you throw it into the biohazard bin. And then after that, you come and disinfect your hands, and then that's it. Thank you.
Okay. So thank you very much. That was the video on the donning and doffing both of the gloves in different methods as well as the masks. Our next guest, just a reminder again, at the bottom of your screen there is the chat bubble and there's the Q&A bubble. Please add your questions there for the question and answer session, and also whatever questions we don't manage to do within the time frame, we have on our website a frequently asked questions FAQ section as well. This video that you just watched now is also available on the NIH website. So today's session will also upload to the website. Our next guest is Mr. Murdoch Ramatuba, who's joining us remotely. He is, and let me just give the correct, he is the National Director for Environmental Health in the National Department of Health. He's joining us remotely, and we are going to ask him just to indicate to us as we put up the slides if he wants to move forward. And you will hear Mr. Murdoch Ramatuba giving his presentation. Okay, Mr. Ramatuba, please proceed.
Good morning.
Thank you.
Yes, sir. Morning, thank you. Thank you very much. I hope you can hear me. I was struggling to hear some of the presentations earlier. Just, I can't see the slides, but what I'm going to try to present on is environmental health guidelines in general. And then on the first slide, in terms of the content, is the issues that look at legislative framework. The next slide is the one that has the content. It's the legislative framework. And then under it, you'll have we'll talk about the international health regulations that refers to the measures that environmental health gets involved in with regards to cross-border movement of people, whether coming in or going out. And then the guidelines as we referred to earlier on, and then accessibility of the documents will also touch to that. And then the next slide, we talk of the purpose, where we are saying that we are sharing here the activities and guidelines for implementation of environmental health practitioners by environmental health practitioners in the fight against COVID-19. In the legislative framework, we've got the IHR that is mostly implemented in the point of entry, as well as the guidelines management of human remains, directions that were issued in terms of the regulations, the disaster regulations, and then also the directive on public hygiene measures that are to be implemented to prevent the spread. And then lastly, we've got the public hygiene strategy and implementation plan, which sort of like sums up everything. Everything. I can see comments that says I'm not audible. I'm going to see what I can do to this.
I hope I can be heard now. Okay, and then the next slide is specifically looking at the IHR 2005, where the purpose they were saying is to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with the restricted to public health risks, and which avoid unnecessary interference to international traffic and trade. Of course, in Article 23, we see that we've got the provisions that, as we are doing, we have done in our points of entry, that a country may, for public health reasons, require travelers to provide information concerning their destination, so that the traveler may be contacted should there be a need, especially if maybe a case is positive, as it has been the case with our initial COVID-19 cases. Information on travel history to determine if they traveled to or from affected countries, examination, which is the screening that we do there. Then in the next slide, where we look at the guidelines for management of travelers in points of entry, also you will see here that this is to guide port health officials on early detection of an ill traveler, and details measures for screening of travelers, which includes the visual assessment when a person comes in, where port health officials that are in the points of entry will be able to see those that are visibly appearing to be not well, and also the temperature screening, which is basically happening in all our points of entry, and then the traveler health questionnaire, which people have to complete for us to be able to trace and to have history of where they're coming from, and then interviewing some of those travelers as they come through. Measures to be implemented for ill persons arriving through these points of entry. It's one of the things that we're also guiding in here. We also guide on the measures for management of transportation of ill persons, that is the medical evacuation from the hospitals to those identified health facilities in all the 9 provinces, and also measures for importation and exportation of human remains. Then when we look at the directions or directives which came out of the regulations, the disaster regulations, you'll see that all the areas that we will be guiding on are basic environmental health issues, which yourselves as environmental health practitioners already know what we are trying to guide on. I think what the guidelines tries to do is a uniform way of dealing with this with these things. However, also given the time frame that we have, or the time slot that we have to discuss these issues, one opted to focus on indicating what is contained in those guidelines and what are the guidelines that are there and how do you access those guidelines. And of course, the copies will be available which I think the facilitators at the end will also be able to indicate in terms of how we can access this. In terms of the environmental health response guidelines, this is set to guide environmental health practitioners on key roles related to the management of the outbreak and the role of EHPs in managing the COVID-19. The key issues there that you'll find is that environmental health practitioners in the role that they need to play. It's the obvious ones, which is to participate in the outbreak response team, which I believe all the participants that are here are in some outbreak response team, whether it's the district outbreak response team within the jurisdiction of the district, the provincial, or a national response team. Investigation of suspected cases, monitoring of the management of human remains, and disposal of the dead, which is becoming more of an issue now that the death toll it's increasing. There are a number of issues that we have picked, which we have tried to guide in the regulations and also in the directives that are there. Also to facilitate and monitor the decontamination and disinfection of affected homes, monitoring the management of healthcare waste, and health education awareness in public hygiene measures. When it comes to decontamination, it is inclusive of public spaces, the public taxi ranks, and all these public areas. I think all of yourselves should or are aware of the directive that was sent by the Minister of COGTA, where she requested all municipalities to go and assess or inspect these taxi ranks that we have for the purpose of assessing the risks that are there and do the contamination, report to your municipal managers, and also report to us so that we can have an indication or an idea of what is happening on the ground. When you look at the next slide, we're looking at guidelines for the management of human remains. Here we refer to monitoring the management of human remains that dies of infectious diseases, including COVID-19. We did a guide in terms of the handling of human remains in mortuaries and funeral undertaker. I think it's also based on the issue of the hierarchy that we were taught about earlier in the beginning of the discussions, where we tried to determine where the risks are as well in terms of the risk assessment and trying to intervene to prevent exposing people, and where we could not, also to mitigate where it needs be. But that is basically what this document will be looking at. We'll be looking at, amongst other things, measures when a patient passes on at home, viewing of human remains, which we try to restrict. Of course, we do know that this is not an airborne, as we are told. However, in terms of human remains, they remain infectious for some time. So handling those human remains may prove to be a risk to those that are actually handling those human remains. Viewing of and then environmental cleaning and control. We did look into that. I think colleagues might have already noticed that there were two guidelines that we issued, one from the Infection Prevention and Control, which was developed looking exactly into what WHO is guiding in terms of what needs to be taken care of, or to be the precautions in terms of environmental cleaning and control. However, we developed the guidelines and the minister's directives on the same issue, where what we did was to increase the control measures, or to be more strict in terms of what needs to be implemented, because WHO give us the minimum guidelines or minimum requirements, but in the same guideline that WHO gave us, they also indicated that countries can come with additional precautions, and that is what we're doing. We're trying to assist Minister and the President in when we say it's medium risk or it's high risk, what are the exact numbers? But you will see as you go through those guidelines that there are some areas where we say whenever you've got 20 deaths in one town per day, then that area now has become a high risk area. That's where government can also start intervening in terms of managing and disposal of human remains, in terms of the guidelines that we have set, also in terms of the minister's directives. So those are the things with regard to that. And then the National Public Hygiene Strategy and the Implementation Plan, which was also signed somewhere early this week. This is to improve and promote public hygiene and cleanliness as a key intervention to the delay and spread of coronavirus in South Africa. So the guidelines in the strategy are for promotion of personal hygiene, environmental cleaning and disinfection guideline, waste management guidelines, water sanitation hygiene guidelines, and then public hygiene communication guidelines. So if you trying to, when you move from the human remains management and you come to the public hygiene strategy, you see there that in the human remains, the restrictions that we're putting there, it's what ourselves as environmental practitioners on the ground need to use to advise our communities, to advise our authorities, and to protect ourselves, to prevent us being infected as well as we do our way. But this one focuses more on preventing everything from the onset when we look at the public environment where people can be exposed. It also talks to the directive that Minister Nkosazana Dlamini Zuma shared or gave with regard to the issues of the taxi ranks, but it also goes further to look at collaborations with other stakeholders like the sector departments such as the Department of Public Works in terms of availing their extended public works program employees to assist where health departments and municipalities might need help. Then going further to slide number 11, in the guidelines for promotion of personal hygiene, we see here that here we give guidance on messages to promote personal hygiene. We've got a team again that is working on the development of IC material on the based on the messages that we've communicated earlier during the outbreak. This looks at hand hygiene promotion, key public hand hygiene messages, and then construction of self-made hand washing taps, or the TP taps as they are commonly known in the mostly in the less privileged communities. The use of alcohol-based hand sanitizers with sufficient concentration of alcohol. Of course, the only time that alcohol is allowed to be used during this pandemic. And then cough and sneeze etiquette, that messages are also included there, as well as other personal hygiene messages to promote personal hygiene, and then of course the social distancing messages. The strategy and the plan talks to what each sphere of governance, starting from national, provincial to municipalities, as well as other stakeholders and sector departments can play in terms of assisting in responding to this outbreak. When we look at the issues of environmental cleaning and disinfection guidelines, we thought we needed to look into this so that we are clear to say, we know what WHO is saying, but this is what we say more. In it, you'll see that it gives guidance on regular cleaning and disinfection of surfaces. It also, and as well, it will look at general cleaning and disinfection of high-touch surfaces, which are the key areas that we are interested in to make sure that we reduce the number of infections, and of course addressing the issue of the gap of the flattening of the curve, and obviously for us to be able to leave these lockdowns as early as possible once we've played our role as environmental health practitioners to assist in controlling these things. The cleaning of minimally touched surfaces, also we did refer to them, and the disinfection of high-touch surfaces, environmental large-scale intervention, disinfection or spraying in public places. It's also covered both in the strategy and also in the environmental health guidelines, where we also advise in terms of the chemicals that can be used for decontamination, because we have learned that people are using everything and any other thing that appears to smell like alcohol. But we have given guidance in terms of the concentrations of alcohol in the solutions that we're using, and the concentrations of chlorine if it is the chlorine-based disinfectant that we are using. We recommended surface and environmental disinfectants that can be used, of course, and the use of disinfectants application. Application of surface and spray disinfectants. Recommended frequencies of spraying for disinfection. If you look at slide number 13, we have, I see my 13 is differing with your slides, but where we talk about environmental cleaning and disinfection guide, we give guidance on regular cleaning and disinfection of surfaces, like your healthcare facility cleaning and disinfection, precautions for staff responsible for cleaning and disinfection, as well as the issues of the PPE, hygiene measures for public transportation, and hygiene measures for workplaces. Excuse me. And then on waste management, we did guide in terms of management of management of waste related to this COVID-19, healthcare facilities and both public and private, management of COVID waste for patients under investigation, and also waste generated in this designated quarantine facilities, waste that is generated in the points of entry, waste in self-isolation or quarantine at homes, and then waste in workplaces or offices and public places. And then lastly, reporting and response protocol where unlawful disposal of healthcare risk waste may be detected. And all this, if you look at them, they are just squarely environmental health interventions. In terms of the WASH programs, the following WASH measures should be implemented to support the control of the spread of the virus. That is keeping water supply and then all safe disposal of sewage and as well as hygiene. And then the public health communication, main communication approaches to achieve public hygiene promotion objectives are advocacy, interpersonal communication, and then community mobilization. The strategy adopts the use of the following communication mediums, that is mass media, information, education, and communication, as well as community mobilization. Then the last slide, I think, is the role of the National Department of Health during displacement of persons in the country. That is a disaster or from neighboring countries. Draft guiding environmental health standards for emergency shelters for homeless people during the COVID-19 pandemic. This we're just communicating it, but it's not yet signed. It's in the process of being signed because we've got a lot of homeless people that are sheltered in various areas per municipalities, but to ensure uniformity, we have provided this guidance in collaboration with social development. And then we've got templates that we have developed for collection of data for the taxi rank, the old age homes, venereal undertakers, and then daily reporting, of which all these things are going to assist us as well, even after the outbreak. In terms of accessibility, we've got the slide that shows you the websites that we are using to keep some of this information that is in the NICD website, as well as the Department of Health website. So in brief, this is what we thought we can share. In summary, one would say that we've got guidelines, we've got directives, we've got regulations. Because whilst as soon as the disaster was declared, the Minister of COGTA developed or promulgated a regulation that made provision for ministries to have directives that looks at their areas. And then the Minister of Health also, based on that regulation that was promulgated, developed the health directives that we are implementing, which were circulated, which I suppose we are already using ourselves, that was signed on the 6th of April. And then also, apart from the directives, apart from the directives, we also have the guidelines that we referred to. We've got the standard operating procedures that looks at an overall aspect, and of course the public hygiene strategy that we referred to, which summarizes everything and guide each sphere in terms of what exactly they can be doing. All these documents, starting from the regulations, are living documents. They are changed almost every second day. There is some new information that comes and warrants those to be changed. And it is justifiable when you're dealing with an outbreak of a virus that not sufficient is known about. And also it being the first of a kind that we're dealing with in the way that we're dealing with it. So always smarter people comes with inputs that gives us, a better view of what exactly we should be doing. You have seen with the disaster regulations, we are being amended almost every second week. Then also the health directives that the minister signed on the 6th of April. We already have amended those directives, which we are hoping minister could maybe by today or maybe latest by Monday might be able to have satisfied himself with the contents and signed, so that we can be guided accordingly. So obviously the guidelines cannot be spared, because they also will need to be changing. And most of the changes that we are making comes from yourselves as the EHPs that are on the ground. When you see how impractically some of the things that we are putting in place, that might need to be changed. And the changes that you'll be seeing from now henceforth will be largely looking at the issues relating to the management of human remains, because there is a lot that is not known, which we're getting to know and getting to implement. And thank you very much for your audienceship. Thank you very much.
Mr. Murdoch Ramatuba from the National Department of Health that has dealt with the COVID-19 environmental health guidelines. Mr. Ramatuba, your microphone is still open. You are part of our panel to deal with any of the questions that the participants, environmental health practitioners, have raised. Can you hear us?
Okay.
Okay. So on screen at the moment is on my far right, your far left, I think on the screen, is Mashele Khole. She's from our SHE department. And next to her is Dr. Odette Valmy from Occupational Medicine Department. And next to me is Dr. Tamisha Singh from the Immunology and Microbiology section. So we have your questions. The first question is home collection by undertakers is a concern. As undertakers believe that they will be affected from the corpse, they collect, their human remains. How are you going to know if such human remains is COVID-19 or not? And that's from Gumere. So I'm not sure who would want to do you want to perhaps respond to that, Mr. Matuba?
Can you kindly repeat the question?
The question,
I didn't hear it clearly.
yes. It's essentially dealing with human remains, collected by the undertakers. And the concern is, how does one distinguish if that particular human remains is COVID-19 or not? The question would be, what measures must be taken? Should all human remains perhaps be viewed as COVID-19 positive or not?
Just for me to be clear, are you asking about human remains that are collected in houses where a person died and not known what they died for?
That's our understanding, yes.
All right. Of course, if the person dies at home, one would not know what could have been the cause of death until a doctor says so. We may have our own.
Apologies for interrupting. Can you improve your sound again?
I hope I'm better now.
Way better. Thank you very much.
Oh,
You were saying, please continue.
Sorry, is this technology? It came while I was already born.
Yes. COVID-19 is putting us on a very steep learning curve.
All right. What happens is that one will never know what a person has died of until a doctor makes that declaration. We can always suspect, but in cases where we know that a person was positive, it's also clear, even though the doctor has not yet declared, we have to treat that as such. And then in some cases where a person had symptoms that might be related to that, it can also be treated as such. But there are some cases where a person does not have symptoms at all, and they die not of COVID-19, of anything else, but they may be positive without showing symptoms, as we already, all of us know that. So advice is that when you fetch such human remains as a funeral undertaker, you apply all the caution that we're giving for dealing with human remains of COVID-19. We have also learned that with our forensic colleagues within the various provincial departments of health, that is the approach, to treat every accident, every unnatural death, whether it's accident, stabbing, gunshots, treat them as potential COVID-19 cases. There is nothing better than applying more precaution than not to and regret thereafter.
Thank you very much. I'm not sure if anyone on the panel would like to add anything.
No, I think it was
Excellent, well done. The next question is, the participant starts by saying that he or she may be wrong, but I'm not observing any messages to the public regarding disposal of masks and gloves. Currently, we are observing an increase of these within the general waste system or the waste stream. As the virus can be present for up to 9 hours and may pose a risk to refuse collectors and possible waste pickers that do not adhere to the guidelines, how should this be addressed?
What we have done, the public hygiene strategy has a section that deals with waste management. And it also talks about the waste that is generated both at homes of patients, in the public spaces, where all these gloves and masks are being disposed haphazardly. Apart from that, we have working with the Environmental Affairs Department, that is the DEF now Department of Environment, Forestry and Fisheries. We have tried to cover ground as much as we can. There is a published, in that published strategy, there is guidance for environmental health practitioners on the ground to use both. They can use the content in terms of developing the messages for communicating to the public, and also for monitoring and managing the waste that is on the ground, because we have seen that as a risk. And as I said, every single day, every second day, you pick up something that you have not covered, and you have to go back and amend your guidelines and regulations to ensure that everything is covered.
Okay, so there was a comment again that the sound is not so good anymore. The next question is, we don't have any administrative controls with the Environmental Health Department in CJ Cronje, and I would assume that's a municipality. The full staff regiment of plus minus 60 people can be found working in confined office spaces. Please advise. And I'm wondering if the guidelines also offered by the president last night in terms of the different risk levels might be applicable here as well. That would be a third. I don't know if there's any comments from the panel.
I think this one should be also for
okay. Mr. Matuba, did you hear the question?
Please repeat, I struggle to hear you.
Okay, can I repeat it for you? So your sound again, thanks. We don't have any administrative controls within the Environmental Health Department in CJ Cronje. I think that's a municipality. The full staff regiment of plus minus 60 people can be found working in confined office space. Please advise.
Hey, I'm struggling. I'm sorry to do this. Can you try to repeat it? I'm struggling to hear you. I hear you are talking about, I hear you, there is 60 people limit that is referred to, but I can't locate what is that are you asking.
I think if I look at the question, they're talking about, the staff regiments, and it comes down to the management of the people within that municipality and how they can deal with social distancing. Maybe putting up petitioning between the individuals if it's possible. So that can be addressed at the floor level within that municipality.
Absolutely, and I think that the health and safety representative can be involved, as well as the management of that particular facility to look at implementing specific protocols for that facility that may help with regards to social distancing within that workplace.
Okay, so the next question we have is, who then works with the immunocompromised if healthcare workers working there is discouraged?
Okay, I think that may have come from my one of my slides, and I think that talks to particularly return to work restrictions when an employee has become positive and then takes some time off from work and then comes back into the workplace. This is particularly for those healthcare workers where now restrictions need to be put on them because they may still be infective coming back into the workplace. So one of the restrictions with regards to healthcare workers is for them not to be involved in the care, particularly of immunocompromised patients. Other healthcare workers who were not infected can continue, care can be continued with those staff members. So it's just to highlight that when one of our employees becomes ill with COVID-19, has some time off leave, time off work, some sick leave, and then comes back into the workplace, we need to think about what kinds of work restrictions need to be placed on them.
Thank you. So the next question is, our universities and colleges have some unique features for back to campus. Do you have, or can you recommend some regulations, SOPs, protocols for academic settings for phased return to campus? And that's from Nodi Jinabai.
I think on the Department for Higher Education, on their website, they do have some guidance documents on the phased return to work. So I think the participants should be encouraged to go to that website.
Okay. And then the next question is, would you recommend that PPE be discarded in a biohazard bin? Well, the panel says yes.
Yes, it also depends, where they're working. Because if they're working in the field, if it's a environmental health practitioner, they may not have it at their disposal at the time, so they may have to package it, within a brown paper bag or some plastic bag before they bring it back to a place where there is a biohazard bin.
Yeah. Okay, and the next question is, how should waste generated from households that have infected people be disposed of? I think that's something, no, this is households again, right? As opposed to people working in the field. Should it be classified as, is that hazardous hazardous waste or general waste? This also refers to the masks and gloves that are worn. So in this case, it's domestic waste. So Matuba, could you respond to that one with regard to masks and gloves within a domestic context and the disposal thereof?
Are they the gloves that can you hear me?
Yes, not so good, but we can hear you.
Okay, okay. Is it the gloves and masks from the communities who are trying to protect themselves, or is it from the households of positive people that are contacts of positive cases?
It's from households.
Or from the general household?
Yes, where there is infected people.
All right. Yeah, we also guided on that in the strategy when we categorize the waste. I think it's a very good question because that's where EHPs on the ground should be assisting in terms of conscientizing the community, because we have categorized those as there is a difference between those and those from the contact, because those that are from the households and those that are from the offices as well, because somebody asked me about those that are generated in the offices, because every department or every organization is trying to be to implement this precaution. So they are categorized in the strategy in terms of which ones will be treated as a health risk, which ones can be disposed in any waste disposal site. So where there is no risk, it can be collected and be nicely packaged and be disposed in the normal waste stream. Because if you try to look at because initially we were thinking that all the gloves, all the masks, they need to be categorized as isolation waste and stuff. But when you look into it, it becomes impractical. If you've got 57 million people using masks and gloves on a daily basis, and about 95% of them are not the risk individuals. That is the general me and you in the office generating this waste. It becomes impractical to say you can send everything to health waste, to the healthcare risk waste treatment facilities. Not only because of cost, but also because of the capacity. The capacity of our treatment sites may not be in a position to deal with each and every waste, because it means every tissue, every mask, everything that you generate, you will put into that, which means we are housing the general waste in the household and labeling that waste as healthcare risk waste. That's the opinion that we have, and that's the discussions that we have been having as well with the environmental affairs. It will appear now in the final version of the document that it's likely to be signed on maybe early next week. I'm not sure about.
Yeah, it would be great if you could provide us with all of the guidelines and a specific document, the new one that you're referring to, and then we can upload it onto the website and the participants can access it from there. So thank you for that. The next question I'm going to direct to a panelist here in the room, Dr. Vorming. Okay. What is your advice on influenza versus COVID-19 as we approach winter?
I think if you notice that COVID-19 and influenza infection have very similar symptoms. So it's very easy to confuse the two, or there's a possibility that we can increase testing when people have flu or the influenza compared to, and we're testing them for COVID because the symptoms are so similar. So one of the advice from the NICD is that people should ideally have the flu vaccine. But there are challenges with the flu vaccine, particularly because these are ordered a year before, and I think nobody had any inclination that COVID would be coming. And so there's limited stock of flu vaccines available in the country. So we know that this is a challenge. Ideally, people should have the flu vaccine so that it would put influenza at bay, and then it wouldn't allow for unnecessary testing for COVID. But there are challenges with getting the flu vaccine because of limited stock availability. So there are challenges to work around that.
Thank you for that. The next question deals with bleach and disinfection. How would you advise the general public on the use of bleach for disinfection?
So a common household bleach is very effective against the coronavirus. So it is recommended as long as you're using it according to the dilution that is indicated by the manufacturer on the bottle. It can be used to disinfect surfaces at home.
And how do you review for effectiveness of cleaning procedures if you are not taking surface swabs?
So currently, because of shortages of testing on the clinical side, it's not recommended to do surface swabs, and therefore it is important to look at the cleaning agent that you use, that it is effective against the corona or envelope viruses. So if you go to the EPA website, or if you go to the National Regulator of Compulsory Standards, they have a list of chemicals that can be used for coronaviruses. And because we going on the premise that these agents have been tested for other coronaviruses like MERS and SARS in the past, that it would also be effective for SARS CoV-2.
Okay. So the next question is, what happens if a patient has tested and is awaiting results? Do we continue to assess him or her using the questionnaire?
Well, the main aim of the questionnaire is to determine who will be tested. So people are screened to see whether or not they have symptoms. Once they have symptoms, and symptoms specific for COVID, they should be tested. And thereafter, the screening tool is not, we need to wait for the results. We ideally should put things in place. So if somebody is symptomatic, been exposed, symptomatic, they need to be removed from the workplace, and rapid follow-up of the test should be done so that contact tracing can occur in the workplace. And then once somebody is confirmed to be positive, they then need to be treated, stay at home, be treated. Once their symptoms are resolved, they need to be assessed in terms of whether or not they can return to the workplace. If the test is negative, they then need to be assessed by a health practitioner to see, is it an influenza virus, what actually is it, upper respiratory tract infection, what is going on, and then they need to be diagnosed and take sick leave appropriately, and when the appropriate time for their diagnosis is resolved, they then need to come back into the work.
Thank you. The next question is dealing with stigma. With the stigma associated with being COVID-19 positive, how can we ensure that information provided during screening is correct?
I think that's a very tricky one, and I think that we need to foster an environment within our workplace that allows, it's blame-free, that allows people to be able to open up and say when they are symptomatic. And we need to, I think in terms of education and training in our workplaces, that environment needs to be fostered so that people understand the risks related to if they don't report, not only to themselves but also to their colleagues. And then they should be encouraged in this environment to report. But I do understand it is a challenge, but we need to have the right environment and try to consciously bring that environment to the fore.
Okay. The next question is, if you have been in contact with a confirmed case, say in the workplace, how long are you required to isolate? Is the 14 days quarantine period also applicable to contacts?
Yes, that is the recommendation from the NICD. If you have been in contact with a non-COVID patient, part of the contact tracing is that, well, you need to be isolated, you need to be monitored for the symptoms while you are away from the workplace, and ideally there should be someone who follows up in terms of in the workplace to see whether or not you're symptomatic, so that should you be symptomatic, quick testing can occur, given that it's a confirmed exposure and the necessary treatment.
Okay. So the next question is, with the number of so many recoveries from COVID-19, what does it mean? Is the virus no longer active in the individual system? Does it mean they cannot transmit to others?
All those are very, very interesting questions, and I'm not sure anybody knows the answer to that at the moment. You know, there's talk in other countries of reactivation. So I think the long and the short of it is that we don't know. We don't know. There are some guidelines in terms of when somebody can be returned into the workplace that have been given by the CDC, Center for Disease Control. And for mild disease, the recommendation is 14 days after the symptoms have stopped. People can be reintroduced to the workplace. That is based on symptoms alone. But there's also some recommendations where testing is readily available in the country. Some recommendations have said that 2 negative swabs, at least 24 hours apart, then somebody can be reintroduced into the workplace. But there's a lot that we don't know with regards to this virus. It's only been around for the last 4-ish months. So we're learning as we go along. So please keep updated with regards to the guidelines. They're constantly changing.
Okay. So you mentioned initial tests on returning to work, in which one must wear a mask for 21 days. Is it the test done to confirm the case, or is it initial test when one returns to work?
Good question, good question. Their recommendation is guidelines on return to work, and it is after the initial test, because currently in South Africa we're testing symptomatic people. You know, we do have limitations of resources, and we want to, the push is to test the symptomatic. So with regards to return to work, this may be an issue if you are no longer symptomatic. Do you just get a test just to come back into the workplace? So some of the recommendations are that you return to work after a period of 14 days after mild disease where you're no longer symptomatic, and then on your return to work you then wear a mask, a surgical mask to kind of contain your respiratory droplets for 21 days after your first test that actually confirmed you positive. So that's where the guidance is.
Well, I'm the bringer of bad news. We've reached our 12 o'clock deadline for this particular session. We have some more questions that we are not able to deal with now as part of the Q&A session. This set of questions will be reviewed by our panel and our experts, and those ones that are not being answered yet in our frequently asked questions will be added to that. So at this point, I need to first just say thank you to our special guest. Are you still with us, Mr. Ramatuba?
Yes, I'm still here.
Maybe just a few seconds from your side as final word to our environmental health practitioners before we close.
Yeah, I think from my side, I would say as a department, we are very pleased with the fact that the ESPs out there are trying their best to assist in combating this outbreak or pandemic. One will rather advise that let's go and look at the guidelines that we have set, so that colleagues can be able to have an accurate way of addressing some of these issues in terms of how we've categorized them, and that the questions that keep on popping here, once they are put together, we'll be happy to generate responses to all of them and communicate them to municipalities and provinces as a circular to assist them so that they can work with ease. And we are anything else, we would like colleagues, when they read our guidelines and they've got information which they think can even serve this township better, we encourage colleagues to send us input so that we can incorporate as we continue to amend our document. And thank you very much for these interventions and these integrations that we have got.
Okay, and we will definitely improve on the technology and the sound for our next session. We want to say thank you very much to Mr. Modok Ramatuba, the National Director of Environmental Health, the National Department of Health. We will collect all these questions that are coming our way. You can use info@nis.ac.za if you've got any further questions once the session has been closed, and we will direct those questions to colleagues within the NIH, especially from the SHE department as well as to Mr. Ramatuba. And thanks to my colleagues here for joining us. That's where we close the session. I think it's important to remind you, in our chat, you'll see that I've placed the website address. There's lots of very important COVID-19 occupational health workplace resources for you to look at. And I've also given you, for example, the link in our chat. If you copy it quickly before we close the session, we'll keep it open for a few minutes. There's the hand wash poster and the hand sanitizer poster. And just a moment ago, I posted the poster dealing with the COVID-19 and the human or dead bodies, right? So there's lots of resources. I would encourage you to go there. Our videos are uploaded there, our posters are uploaded there, as well as this session itself will also be uploaded. So at this point in time, I need to say thank you very much to all of you. You are essential workers in this battle to deal with COVID-19. From the NIH, we will see you on a future session of the COVID-19 platform. Thank you.